All right, good morning. My name is Dr. Julia Toman. I'm an assistant professor here at the University of South Florida in the Department of Otolaryngology in the Division of Facial Plastics and Reconstructive Surgery. And this morning I'm going to be talking about lasers and skin resurfacing in the field of facial plastic surgery. So just a brief outline of the talk, we'll go over the biophysics of lasers, the different types of lasers that are available, and then we'll talk a little bit more about the clinical applications of lasers. And then we'll focus in a little more closely on facial rejuvenation and the use of lasers as well as chemical peels in facial resurfacing. This has become an area that has ended up being very widely tested on the in-service. And so hopefully we'll pull up some key salient points to help us all get through that. So first we'll go into the biophysics of lasers. So laser is actually an acronym. It stands for light amplification by stimulated emission of radiation. And lasers emit light energy that travels in a very specific waveform. The wavelength is the distance between the two peaks, as you can see in the picture. And the amplitude is the height of that peak, and that's related to the intensity. The frequency is the amount of time required to complete one cycle, or the period of time between, a peak to a peak. All lasers have four components, and those components are an excitation mechanism, which is their power source, a laser medium, an optical cavity or resonator, and then a delivery system. And essentially the excitation mechanism pumps energy into the resonating chamber, which contains the laser medium. And then the energy is dumped into the resonating chamber, which elevates the electrons in the medium to a higher energy state. When half of the atoms in the resonating chamber reach this highly excited state, then within the population, an inversion occurs. And then there's amplification where electrons then excite each other along the reflective mirrors that make up part of the resonance chamber. And this energy, until this energy is ultimately released through the delivery system. It's important to realize that laser light is more organized and intense than normal light, and it's monochromatic because it comes from one medium and it's collimated. Most clinical lasers in facial plastics use an electrical excitation mechanism, but there are others available. So we'll talk a little bit more about how a laser interacts with the tissue. And there's four options. It can either be absorbed, it can be scattered, it can be reflected, or it can be transmitted. And if it's absorbed, the extent of that absorption is determined specifically by its chromophore. There's a range of effects that lasers can have, whether they're introduced at a low energy or high energy. Energy density is the power density multiplied by the time of exposure over the surface area, which is called the spot size. So varying the spot size or exposure time will then alter the effects it has on the tissue. So for instance, as the spot size of a laser beam decreases, the amount of power reaching a particular volume of tissue increases. So the power remains the same, but if you're putting it over a smaller surface area, there's going to be more intensity in that smaller surface area. Another way to change how lasers interact with tissue has to do with laser pulsing. So pulsing makes use of the idea of thermal relaxation, and that's the amount of time required for an object to dissipate more than 2/3 of the thermal energy that it's absorbed. So pulsed modes will alternate between periods of being on and periods of being off, as opposed to the laser being in continuous mode and just being on. When the energy is not reaching the tissue in these on and off periods, the heat is then allowed to dissipate from the tissue. And if that off period is longer than the thermal relaxation time of the tissue, there's less chance of damaging the surrounding tissue with heat conduction produced by the laser energy. So there's a variety of pulse modes available. Certainly the energy can be at a pulse time where the laser is just on. The energy can be shuttered. So there's a continuous wave that's blocked at periodic intervals by a mechanical shutter. And then there's a non-shuttered pulse mode with a super pulse. And basically the energy isn't just blocked during the storage time, but it's actually stored up. And so when it's released on the interval, there's a peak energy in the super pulse that greatly exceeds the continuous or shuttered modes and allows for delivery of short bursts of very high energy into the tissue. So let's talk a little more in depth about the various characteristics of the lasers that are available. And we're going to talk first about electrically excited lasers. The first one we're going to talk about is by far the most commonly used. It's the carbon dioxide laser. And its wavelength is 10,600, 600 nanometers. Its chromophore is water. It does have to utilize an aiming laser in order for it to be utilized. And the effects of the carbon dioxide laser are very superficial. There's high absorption and minimal scatter at the skin level. The Nd:YAG laser has a wavelength of 1,064 nanometers, and it is well absorbed by pigmented tissues specifically. It's transmitted actually through the superficial layers in order to scatter into the deeper layers. And so there's a greater depth of penetration with the Nd:YAG compared to the CO2, making it much better suited to coagulation of deeper vessels. But this can also unfortunately predispose to postoperative scarring because of the scatter in the deeper layers. Historically, the Nd:YAG was used for port wine stains, but it's been largely replaced by yellow wave lasers, which have a little less risk of scarring. We'll talk a little bit more about them in some of the upcoming slides, but they remain useful as an adjuvant for nodular port wine stains. Additionally, the Nd:YAG can be fitted with a contact tip, either made of sapphire or quartz, which changes the physics of the laser. This contact tip is directly applied to the skin and it allows it to act as both a cutting and coagulation mechanism. And it's actually the heat of the tip that's used to cut rather than the original laser wavelength. So it acts a little bit more like a Bovie cautery. The KTP laser has a wavelength of 532 nanometers, and its chromophore is specifically hemoglobin. The KTP is basically an Nd:YAG laser that's frequency is doubled, and thus its wavelength is halved by passing the energy through a KTP crystal. And this results in a green light, which corresponds with the absorption peak of hemoglobin. Its tissue penetration and scatter are between the CO2 laser and the Nd:YAG. And its energy delivery is via a fiber. So there's two options for that. There's the non-contact mode, which vaporizes and coagulates. And then there's the semi-contact mode, where it acts more like a cutting instrument. At high energies, it acts like a hot knife, whereas at lower energies, it will function more to coagulate. The argon laser actually produces a range of wavelengths between 488 and 514 nanometers. And this is due to the makeup of the resonance chamber that allows it to produce a band. Like the KTP, it's also absorbed by hemoglobin and has an intermediate scatter, again, between the CO2 and Nd:YAG. Its delivery is via a fiber optic cable. And due to its chromophore being hemoglobin, there is high absorption in skin vascular lesions that absorb the energy from the argon laser. The continuous yellow dye laser comes in at a wavelength of 577 nanometers, and it's tunable, so changing the dye in the activation chamber and uses an argon laser to excite the dye. It is also well absorbed by hemoglobin and uses a delivery system of a fiber optic cable. It also utilizes a hexascanner handpiece, which can pulse the laser energy in a random pattern with this outline of a hexagonal outline. And they are really ideal and become the laser of choice for benign vascular facial lesions. The copper vapor laser actually has two separate wavelengths. It can either be 511 nanometers, putting it in the green spectrum, or 578 nanometers, putting it in the yellow spectrum. And its laser medium is copper that's been vaporized electrically. It also uses a fiber optic delivery system. And when it's utilizing the yellow light, it's good for, benign facial vascular lesions. And when utilizing the green light, it's better for pigmented lesions such as freckles, nevi, or keratoses. The final electrically excited laser that we're going to talk about is the diode laser. And the diode laser uses superconducting materials that are directly coupled to a fiber optic delivery system that result in laser light emission of varying wavelengths. And the wavelength is then determined by the material used. They're characterized by a lot more efficiency than other lasers because there's direct conversion of electrical power to light with a 50% efficiency. So they produce much less heat than other laser systems. And so they can be constructed without cooling systems. This brings us into our Flashlamp-Excited Dye Lasers. They have a wavelength of 585 nanometers, which lines up with the peak absorption of oxyhemoglobin specifically. And at this wavelength, there's less absorption by other chromophores, such as melanin, and there's also less scatter in the dermis and epidermis. Its medium is a rhodium dye, and it's excited optically by a flash lamp. It again utilizes a fiber optic carrier and is pulsed at 450 microseconds. And this pulse time is based off of the thermal relaxation time of ectatic vessels found in benign vascular cutaneous lesions. So its use is mostly for these particular types of lesions. The Erbium laser has a wavelength of 2,940 nanometers, and its chromophore is water. It is strongly absorbed by water 12 times more than a CO2 laser, and like the CO2 laser, requires an aiming beam. The Ruby laser, another flash lamp pumped laser, has a wavelength of 694 nanometers, and it's most often used with the Q switch, which is that high peak energy, short burst pulsing mode, which is utilized best for deep penetration into the tissue. It is strongly absorbed by melanin as well as other pigments. And so it's used for heating hair follicles in hair removal, as well as utilized in tattoo ink removal. The Alexandrite laser has a wavelength of 755 nanometers, and it's a solid state laser that again is flashlight pumped. It's specifically absorbed by blue and black tattoo pigments, as well as melanin. And then intense pulse light is not a laser, but it's an intense non-coherent pulsed spectrum between 590 nanometers to 1200 nanometers. And the pulse is adjusted for selective photothermolysis. It's used primarily for telangiectasias and skin discolorations, as well as to prevent the effects of photoaging. So now that we've gone over sort of the basics of the lasers that are most commonly used or available to us, we'll talk a little bit more about the applications of laser in clinical practice. Port wine stains are a congenital capillary malformation. They are present at birth. They are flat, pink and red, and then tend to darken and thicken with time, separating them from hemangiomas, which tend to involute over time, most commonly. And their histopathology shows large ectatic vessels in the reticular dermis. So based on the lasers that we've discussed, what would be an option in order to address a port wine stain? Would it be a continuous yellow dye laser, a CO2 laser, an argon laser, or a KTP laser? I'll give you a minute to think about that. And then if you have your choice, we'll move on to the next slide. So when we talked about yellow wavelength lasers, that the yellow wavelength are most selective for photothermolysis of ectatic vessels. And there are a variety, the flash lamp excited, the copper vapor, as well as the continuous yellow dye. And these work by heating the blood itself within the vessel, and then that heat is conducted to the vessel wall. So there's less absorption by the melanin and less scatter compared to the KTP or argon laser options. The CO2 laser, in order for it to get to the dermis, again, because it's highly absorbed in the epidermis, would have to ablate the overlying epidermis and part of the dermis and vaporize that. So you're going to get a lot of scarring and hypopigmentation. The argon laser was extensively used in the past because the blue-green light is well absorbed by oxyhemoglobin, but it was found to be complicated by hypertrophic scar. And the KTP laser was also used. It has a very similar absorption profile, of course, to the argon, but it had varied results. And so when you're thinking about these sort of lesions, the yellow wavelength options are the best. Another lesion that you often see is telangiectasias. These are small ectatic vessels within the dermis. They're an acquired vascular mark. And the laser options for them, again, would be the copper dye laser, the continuous yellow dye laser, the flash lamp excited, or a 532 nanometer long pulse diode laser, again, bringing it into the yellow spectrum of the laser spectrum. But there's another type of telangiectasias, which are often the bane of at least a junior resident on call. They always seem to come in, which is hereditary hemorrhagic telangiectasias, or Osler-Weber-Rindo. It's an autosomal dominant trait that results in multiple telangiectasic lesions on the skin and mucosal linings, which are incredibly friable and often result in bleeding that is difficult to control. This is due to the ectatic vessels within an incomplete surrounding muscular structure, which is found on histopathology. So when thinking about how to address these, what sort of laser options are good for HHT? Is it the CO2 laser, the Nd:YAG, the KTP, or the Argon Laser? I'll give you a minute to think about that. And then we'll go on to look at the options. So again, the CO2 laser would not be ideal. It causes superficial vaporization, which is just going to result in more bleeding. So don't use that option. The Nd:YAG isn't absorbed. It's got a deeper penetration, which does make it a very effective coagulating laser, but it's not necessarily absorbed by oxyhemoglobin, which KTP and Argon are. So both of those are good options. The thing that makes KTP a better option in this particular case is that it has a dedicated nasal instrument that's been designed. So you will often see people using a KTP laser to address these sort of lesions. Hemangiomas, again, we're looking at the vascular specificity with the KTP and Argon. And again, the Nd:YAG is good for nodular lesions and because it has a greater depth of penetration, so it can get deeper into the dermis. When we're looking at pigmented lesions overall, whether they're freckles, cafe au lait spots, congenital nevi, melasma, as well as exogenous tattoos or accidental tattoos from explosion, lasers can be used to remove these pigments. And the mechanism isn't totally well understood. It's thought to be possibly due to photoacoustic damage in the cell, due to the rapid heating and expansion of the melanosome, which causes potentially a breakup of pigment, and then you have systemic rephagocytosis and clearing of the pigment in that mechanism. But for pigmented lesions, you can use the pulse dye laser. It's a short wavelength with shallow penetration, and it's good for epidermal pigment like lentiges, freckles, cafe au lait spots, as well as brightly colored pigments. It's with its shallow penetration, it's more likely it's hitting the melanosomes rather than the melanocytes in the deeper skin structures. So you're less likely to damage the melanocytes and cause hypopigmentation, but there is some risk of recurrence of some spots over time. For pigmented lesions from tattoos, always think Q-switch. These high energy, short burst, pulsed modalities. Anytime there's a question about a tattoo and a laser, the easiest way to weed out possible answers is anything that doesn't have Q-switch in it is not a good option. But a little more specifics about them and about tattoos in general. Amateur tattoos respond more favorably in fewer treatments. The thought is there's less consistent thick dye that's been injected into the skin. And the black tattoos are easier to remove than colored tattoos. It's the green tattoos that have a variable response and red tattoos that are the most problematic. The ruby laser, like we already talked about, has a deeper tissue penetration, so it's highly effective for amateur tattoos and moderately effective for professional black tattoos. The Alexandrite laser hits the blue and green tattoos, and the Nd:YAG is used for red tattoos. All right, we're gonna leave lasers behind a little bit and then sort of refocus on them again after we talk about facial rejuvenation. And you can't start talking about facial skin rejuvenation without, of course, going over the Glogau scale. This is a way to communicate with colleagues talking about how we define photoaging of the face. And so group 1 is very mild, 28 to 35, there's no wrinkles. You maybe have some early photo damage, the occasional pigment change, there's no keratoses, minimal wrinkles, maybe with facial expression, but none at rest, and requires minimal or no makeup in order to prevent or show an unblemished surface. Group 2 is moderate. That's typically 35 to 50-year-olds. You will get wrinkles in motion. There's moderate photo aging, so there's some early brown spots, maybe some keratoses that are palpable, but they won't be visible. Parallel smile lines will begin to appear, and most, at least women, will start to wear some foundation to cover up these findings. Grade 3 is advanced, typically in the 50 to 65 range. You have wrinkles at rest. There's advanced photo aging. There's obvious discolorations. You'll start to have visible capillaries, visible keratoses, and typically people will start to wear heavier foundation in order to cover these differences in skin tone and quality. And then the last group, group 4, is severe, usually found, starting in 60 and up. You'll see there's a little bit of overlap in the age range between 3 and 4, and basically it's wrinkles everywhere. Think of like an old weathered face that's somebody who's worked all their life in the sun without any sun protection. So there's severe photo aging. You can have a yellow or gray skin color. You probably will have had prior skin malignancies, and there's sort of wrinkle throughout. There's no way that a makeup can cover the abnormalities because it just cakes on and cracks. And so using this sort of fundamental background about how we think about photo aging of the skin, we can talk a little bit more about the role for skin resurfacing and rejuvenation. So the principle is that there is selective photothermolysis utilizing the chromophore water to vaporize thin layers of tissue with minimal heat diffusion. And so resurfacing lasers have to be capable of delivering sufficient fluence during a brief time to achieve vaporization during a single laser pulse. And for skin, this is about 5 joules per centimeter squared in less than 1 millisecond. And laser resurfacing is good for rhytids, photo aging, including actinic keratosis or dyschromias, as well as scarring related to trauma or iatrogenic causes or acne. There are both ablative and non-ablative rejuvenation lasers, which we'll get into a little bit more in depth in the coming slides. And then one of the newer ideas about lasers that's come about that I think has really revolutionized the use of laser for facial rejuvenation has been the idea of a fractionated laser. And with a fractionated laser, only a fraction of the skin in the target area is treated, leaving the intervening skin untouched. And this is basically accomplished by the laser emitting numerous narrow microscopic columns. And then there's higher energy within those small spot sizes, so that increases the depth of the laser. But by leaving intervening areas of skin untouched, it allows for more rapid re-epithelialization and a shorter recovery time, as well as often less scarring because there has been less uniform damage to the skin. So ablative lasers are typically the CO2 or the Erbium laser. They will remove the epidermis and portions of the superficial dermis. There is additionally heat transfer to the underlying collagen, which will cause contraction and some remodeling, where you can actually see skin tightening occur at the same time. There is less coagulative effect with the Erbium versus the CO2 laser, and this results in a shorter recovery time with the Erbium laser. There are some important factors in any resurfacing. Darker skin certainly has a higher risk of dyspigmentation because these methods do potentially interact with the melanosomes and the melanocytes, leading to difficulties with coloration following resurfacing. And like we already talked about, re-epithelialization, when you're using a fractionated, will come from these patches of untouched skin, but re-epithelialization really depends on adnexal structure, so the pilosebaceous unit, where there will be sort of rests of epithelial cells that can migrate out and resurface the skin. There's a few points that often come up about contraindications to laser resurfacing or ablative laser resurfacing. Scleroderma or previous radiation are contraindications to ablative laser resurfacing, and that's because they will affect the ability of adnexal structures to provide for reepithelialization. You think about both of these decrease the number of pilosebaceous units. Some people talk about taking a punch biopsy and looking specifically for number of pilosebaceous units to see if, in an individual patient, this might be an option for them. But this is, at least for board considerations, considered a contraindication. And isotretinoin, which can also decrease pilosebaceous units, is considered a relative contraindication for ablative laser resurfacing. And then certainly there are adverse effects that you need to counsel patients on when looking at laser resurfacing. There is often some persistent erythema, and how long depends on the laser and whether it's fractionated or unfractionated. But in a CO2 laser, you can expect to be red to pink for up to 3 months. I will warn patients. The erbium YAG is less, usually about 1 month, but people can be pink for longer. And one of the things that sometimes comes up is you can use green-based makeup to help hide it. They're on opposite sides of the color wheel. If you think back to sort of elementary school color wheel, red is opposite to green, and so this helps to hide the red color. Using a fractionated laser does decrease the time of erythema, usually less than 1 month, but obviously there's an incredible amount of variability between patients. And then dyspigmentation can occur in a number of patients, and 30% of patients will get post-inflammatory hyperpigmentation. This is treated with topical steroids, hydroquinone, retinoids, and glycolic acid. And it's important to note that hyperpigmentation is more likely to occur in skin phototype 3 or higher. You can also get an eruption of oral herpes, as well as acne or milia as part of the healing process of the skin with reepithelialization. People will get these little comedones and whiteheads, and it's important to use gentle cleansers, and some people will require some oral antibiotics to treat these. And all patients getting ablative laser resurfacing should receive at least a prophylactic dose against herpes, even if they have no history of herpes eruptions. So we'll get now into non-ablative lasers, and these are thought to act by stimulating the skin resurfacing by targeting deeper collagens, pigments, or blood vessels. The good thing about them is that there is definitely less downtime, but as a result, they also have more modest results. One of the most commonly used is these pulse light devices, so either IPL or BBL. This is a broad spectrum light that targets a variety of chromophores, and it utilizes a crystal and a gel that's cooled to increase conduction and protect the skin from decreasing the amount of heat that actually stays in the tissues. And these are very effective in improving early telangiectasias as well as pigment disharmony, and can improve skin texture overall with a little bit of subtle thickening of the skin and removing of those sort of early lines, can give people a very good result. I was taught that these sort of devices are good for stopping the clock a little bit. So, and there's something that need to be sort of repeated on a routine manner, but they're not very good at turning back the clock the way an ablative laser will do. But certainly an option for folks, and certainly less downtime. There's also been some use for non-invasive skin tightening techniques for people that want to, utilizing the depth of penetration to the collagen level and subtle tightening of the collagen to tighten up either along the jawline or in the neck. So one of these options using radio frequency is Thermage, is the the brand that's most typically known for this. I have no financial disclosures. I don't have any relationship to any of these devices, but that's sort of the common name, like Kleenex. And it basically generates an electrical current that generates heat within the dermis, and this leads to collagen remodeling and subsequent skin tightening. And it's a subtle result, but you can see sort of a modest improvement of this early gel formations in this patient in this picture. Some other options with sort of similar ideas are the use of infrared lasers in the wavelengths of 1,000 nanometers to 1,800 nanometers. These again have a deeper penetration into the reticular dermis where the collagen level is, and in remodeling the collagen and tightening the collagen, you get resultant skin tightening. And then the intense focused ultrasound with Ulthera, you get tightening of the skin due to delivery of thermal energy again into the dermis and subcutaneous tissues. The underlying principle in all of these is targeting the collagen in the deeper layers of the skin to with some heating mechanism in order to get them to tighten and result in changes in the overlying skin structures to improve subtly sometimes contour. We'll talk briefly about chemical peels. This is not going to be a sort of tutorial on how to do all chemical peels, but I wanted to include this because it still shows up on a lot of exams, and so I'm going to just highlight some of the key information I think is important to know about these. So indications for chemical peeling are the same as laser resurfacing. We use chemical peels for resurfacing the same way we do for lasers. So photo damage, rhytids, actinic changes, dyschromia, as well as acne scars. And there's different layers of peels depending on how much of the skin you're taking off. A superficial chemical peel will remove either the stratum corneum or the entire epidermis, but does not address the dermis. And so it's not going to address rhytids. These tend to be things like fruit acids and things that are typically applied by an esthetician. They can be done sort of in the office with no sedation types of peels. A common one is a TCA at a 10 to 20% strength. You get a light frost, and the endpoint is a level 1 frost, which is erythema and some streaky white. It's good for very early wrinkles, sort of fine line type changes, as well as very mild photo damage. And then the alpha hydroxide acids, whether it's glycolic acid or lactic acid, cause desquamation by decreasing the corneocyte cohesion. One of the fun facts that they like to test on sometimes is that glycolic acid specifically must be rinsed off of water and neutralized with 5% sodium bicarbonate after 2 to 4 minutes. And then the last of the superficial chemical peels that will, or one of the other superficial chemical peels, I'm sorry, is Gesner solution, which actually combines 2 alcohols and 2 acids. So resorcinol, salicylic acid, lactic acid, and ethanol. It's a keratolytic agent. So again, it's going to cause a sloughing of the superficial skin. It's used very commonly for acne treatment, but it's also an extremely effective preparation for a medium depth peel, which we'll discuss in a moment. And then one final superficial chemical peel is a 30% salicylic acid peel. It's good for early to moderate photo damage. It lacks the resorcinol found in Gesner solution, which can be cardiotoxic, which is important to remember in these patients. And unlike the glycolic acid, it's a self-limited peel, so it doesn't require any neutralization. A medium depth peel results in destruction of the epidermis with inflammation and or damage to the papillary dermis and potentially the upper reticular dermis. It's done in a single treatment as opposed to a series of treatments. So the superficial peels tend to be a series of treatments where you get desquamation of the skin and a fresher, more a fresher look. A medium depth peel will cause a greater change with one peel. And then it's meant to address moderate photoaging, dyschromias, melasma, rhytids, actinic keratoses, and some early epidermal growths because it is taking off down to the dermal layer. Typically, it's a combination of either Gesner's or 70% glycolic as a preparatory agent to cause some desquamation of the epidermis, and then a 35% TCA peel. So that's a stronger strength than the superficial peel with the 10 to 20% TCA. You will pre-treat these patients with retinoic acid, which is thought to accelerate epidermal regeneration following the peel, as well as some topical bleaching agents to prevent post-inflammatory hyperpigmentation as they're healing. The course of the peel, they'll peel over about 4 to 7 days following application of the peel, and then they're pink for 2 to 4 weeks, like the ablative laser resurfacing, because you are removing this top layer of skin and waiting for the skin to regenerate. Oops, skipped one slide there. And then finally, we talk about deep peeling, and this is inflammation that extends through the papillary dermis into the reticular dermis. Its indications are moderate to severe photoaging. And the classic example is the Baker-Gordon peel, which is made up of phenol, water, some soap, and croton oil. It's important to remember that phenol is cardiotoxic. These patients need to be receiving cardiac monitoring if a Baker-Gordon peel is being used, and aggressive hydration. And the other factor is that through a series of experiments, it was determined that actually the primary agent responsible for the peel is croton oil, not the phenol, as was previously thought. The big risk with these deep peels is the risk of alabaster skin, and it was when these were commonly being used, you would get this porcelain white shiny appearance to the skin sometimes. It was very pathognomonic for having used a deep peel. My experience is that a lot of the deep peeling has, at least in my experience, been supplanted by fractionated ablative laser resurfacing, which certainly has its own risks, but doesn't have this risk of alabaster skin, and I think gives a very nice result. And in my practice, that's typically what I would offer a patient if they have that extent of photoaging changes that they would want to address. So I hope this was a helpful, if brief overview about lasers, the use of lasers, and discussion of facial rejuvenation with skin resurfacing options, whether it's lasers or chemical peels. Thank you so much for your attention.